Hyperthyroidism, or your thyroid gland working overtime, is a condition which affects the thyroid gland, and as the word says, hyper means overproduction of the thyroid hormones. Before we dive into this presentation, we are going to talk a little bit about the anatomy of the thyroid. So the thyroid gland is located in front of at the front of the trachea. It has a right lobe, okay, which you can see here, and also a left lobe. Those two lobes are connected with an isthmus, okay, a connection between these two lobes, and the pathology usually occurs at this area. Okay, sometimes it affects the back side, but most of the time is found on the front side. It is located under the thyroid bone, as you can see, and at the front of the trachea. Okay, so the patient comes in and she says, "Doctor, I've been feeling really strange lately. Okay, I'm always nervous, shaky." Okay, so some hints here. My my heart feels like it's racing even when I'm resting. Okay, so her heart feels like it's racing, so she is having some type of palpitations even though she's resting. She has lost around 7 kg, okay, which is a lot, even though she's actually eating more than usual. Okay, so she's eating more, but she's losing weight. Okay, that's a symptom. I can't stand the heat anymore. I sweat all the time while everyone else seems comfortable. Okay, so she's sweating even though we are talking about room temperature. Okay, also a hint. My hands keeps trembling. Okay, so she's shaky. We already mentioned that in the beginning. She has trouble sleeping, which can be a reason, different reasons. She may have insomnia and all other diseases, other conditions, but in this case, that adds up to the symptoms. And my family says my eyes look bigger than before. Okay, so this is a sign that her family members noticed. She's also noticed a swelling in the front of her neck. What could be causing this? Okay, so this is classic, okay, textbook hypothyroidism. Most of the patients won't come in with this, they won't, okay, I'm mentioning they won't come in with this type of symptoms and signs which are textbook like, but they'll mention stuff like losing weight. Okay, so they have lost weight. They'll say that they have anxiety, which may be a form of their heart racing. Okay, they may feel anxiety. They may not. They may feel trembling. They may have trouble sleeping. Okay, people come in having trouble sleeping and sweating. Okay, it's also a common sign, a common symptom. So what would you do next? Okay, you may pause the video and think, what could you do next? Okay, to diagnose hypothyroidism. So the next step would be to evaluate the patient. Okay, and one of the steps you are actually doing while you are talking to the patient. So while you are talking to the patient, you are actually checking, okay, checking their neck, inspecting their neck. You are checking the contour that follows the trachea, okay, especially on the lateral sides, and checking for increases. Okay, sometimes it's difficult, especially for in people who have a thicker neck. Okay, but in most of the times you can check an older photo that they have of themselves and compare it to the patient themselves. Okay, so you check the contour. Okay, and as you can see here, compare both of the pictures, both sides. So the left side, this side, is an increase in mass. Okay, and the right side is a normal thyroid gland. So a bigger thyroid gland on the left side, and on the right side you have a normal thyroid gland. And as you can see here on this patient, because he's thin, you can clearly see the difference between the right side and the left side. You may do also some other some other check some other signs and evaluations. You can palpate their neck. You can do that sitting in front of them or at the back side. From the back side, you are actually touching their neck using your fingertips But please make sure that your fingertips are not cold and they are normal temperature, because most of the times the patient will jump, okay, and he will be scared. So touch their neck, inform the patient before you touch their neck, and check for an increase in mass of the thyroid gland. Sometimes you may use also the swallowing technique. So you tell the patient to swallow while you press from the lateral sides, okay, and check for the increase in mass in the thyroid gland. Another sign, which is a common one, especially in patients who have a retrosternal goiter, okay, so it's called the Pemberton sign. Actually, this does not happen only to patients who have hypothyroidism, goiter, okay, it may happen also to patients who have lymphomas. So as the mass, any type of mass, it can be a tumor, a lymphoma, goiter, is pressing against the superior vena cava, it's blocking the blood flow the head from the neck and the head part downwards. Okay, so when the patient increase, we tell the patients to raise their hands and their arms. They are, you can see that their face turns red, but their body is pale. Okay, so the blood is actually trapped, okay, above the neck part. Okay, so including the neck and the head. So how, we have taken the anamnesis, we talked to the patient, we did a clinical evaluation, we are sure, we are 70% sure we are talking about hyperthyroidism. So what do we do next? We should diagnose it, okay? We should have a paper or a tests. We should use tests that we can confirm that this patient has this type of disease. Okay, the diagnosis is usually done through blood work. Okay, we test the hormones, especially TSH, T4, and T3. Even though T3 is not located in this picture, but we test it. So in our case, when we have hyperthyroidism, TSH is low. Okay, because we have an overproduction of T4, overproduction, we have a low TSH, okay? And since you can check this chart, I took it from geekymedics.com. Okay, so TSH is decreased, T4 if increased, that means primary hyperthyroidism. It can be Graves' disease and other diseases. We'll check them out later. Okay, keep in mind TSH is decreased, T4 increased. Okay, TSH decreased, T4 increased, T4 and T3 also. We may also test for TREAB, which is which is a short form, an abbreviation for thyrotropin antibodies. Okay, so these antibodies which attack the thyroid gland, the TSH most commonly. So it takes the place of the TSH binding component. So it hurts, okay, it attacks, it antagonizes the TSH receptors. Okay, we can check that, especially in Graves' disease. This is mostly for Graves. Okay, Graves' disease. We can also do a radioactive iodine uptake test. So we give radioactive iodine to the patient, and we using special scans, we check their thyroid gland. We check for hot nodules, okay, and the hot nodules is where iodine is being collected. Okay, so if it's more collected, then you have more iodine there, it shows up more on the scan. Okay, and of course, we can use the ultrasound, especially the Doppler, to detect, okay, something known as thyroid inferno. Okay, so as you know, inferno means a lot. So hell, in a way, the thyroid inferno, a lot of blood flow which goes to the thyroid gland, which gives us a clue that something is happening there, which needs a lot of oxygen, a lot of glucose. So that means that it produces more, which in a way tells us that we are talking about hyperthyroidism. Okay, and here you have a picture which tells us that. So what are some causes, okay, okay, possible causes of hyperthyroidism. Since we talked about hypothyroidism, what are the mostly the causes? It can be Graves' disease, okay, and key clinical clues which differs it from the other diagnosis is that they usually have exophthalmos. Okay, so their eyes are popping out. Okay, they are popping out. They have huge eyes because of a process known as exophthalmos. Okay, it's an autoimmune process which attacks the uh, tissue behind our eyes, okay, which makes the eyes pop out. Okay, so for Graves' disease, we should keep in mind we have exophthalmos, and the thyrotropin antibodies are positive, okay, which are negative on the others. Okay, toxic adenoma is also a possible cause. Toxic multinodular goiter is especially found in older adults. Okay, it's found in older adults, and it does not have a thyrotropin, sorry, antibody. Okay, so it is negative. You can have also postpartum thyroiditis, so painless thyroiditis, factitious hypothyroidism, and a lot of more conditions which can cause hyperthyroidism. So, okay, you send the patient to endocrinology, they did all the tests, they confirmed that we are talking about hypothyroidism. So, how do we treat it? First and foremost, we should apply a symptomatic treatment, okay? Because the patient came in first and foremost because of the symptoms. Okay, the symptoms included palpitations, sorry, their heart racing, right? The patient mentioned their heart racing. So we need to use beta blockers. Okay, so we use beta blockers to stop their symptoms, but this not does not treat the disease itself. It stops only the symptoms. So we use propranolol. Okay, we can use 20 to 40 depending on their weight and their age, orally every 6 to 8 hours, a maximum dose of 320 milligrams per day. Okay, you cannot exceed that. Then you should attack the disease itself. Okay, so in our case we should apply anti-thyroid drugs. Okay, methimazole, okay, as we say it in the Balkans, methimazole is actually the most common drug, the first line treatment, and it is applied 5 to 10 milligrams per day. We do not use methimazole only if we have a first trimester pregnancy where we use propylthiouracil, or we have allergies to methimazole. Methimazole is almost always used except these conditions. So pregnancy and allergies. Okay. The next part is propylthiouracil or PTU, 100 to 150 milligrams every 8 hours, and it's commonly used during the first trimester of pregnancy. And as a definitive treatment, we have radioactive iodine, okay, as a definite treatment, which destroys those nodules. But we should be careful, this cannot be used in pregnancy, okay, during pregnancy. And also thyroidectomy is one of the definitive treatments. But most of the time after the definitive treatments, the patients should go back on levothyroxine. Okay, they should go back on levothyroxine because their thyroid gland is not producing any more hormones. Okay. Yes. So basically, that's it. That's it with hyperthyroidism. I want you, if you want, you can subscribe and please check my channel. As you know, I'm new, so I always did most of the videos that I did before. I did them with AI. Now I'm doing them myself. Okay. So have a nice day. See you on the next video.